So we want to talk about geropharmacology and get this moving so that this lecture can proceed and you have a good grasp. I've kind of provided hints about medications and interactions with older adults up until this point of the lecture content. This unit will actually be very heavily noted on your next exam, so you can be ready for that because it's so important. It can really interact with a lot of different areas and cause significant problems with our older adults. So it's something we need to have at the very top of our list and use our resources to help promote and understand how our medications and drugs are actually working for our older adults and how they might be harming or providing adverse effects for our older adults. So, heavy on the next exam, important content. Some of this in part one especially is going to be review from some of the pathophys and normal changes of aging content that we've already covered. So consider that part two. We didn't cover a lot of that, however, on the first exam, so you will see some of this on the next exam, like I mentioned. So let's start. The problem. Basically, the problem is that any dose of medication produces a different and sometimes unexpected response in an older adult compared to a younger patient of the same gender and the similar body weight. And that has to do with some of the changes in our bodies as we've gotten older. I could tell you, first of all, that it kind of sneaks up and surprises you because people are like, I've been taking this drug for like 10 years. Why would I suddenly have this problem? And my mother-in-law is a really great example of this. She is now 72. She's marvelous. She looks way younger than 72, although her hair is white now. She's really pretty healthy and regal looking. You know, you don't think there's too much going on there. But she called me up and she says, well, I've been having this problem and I'm not sure what's going on. And we talked about her medications. And then she called me the next week and she said, well, I talked to my doctor and he recommended I stop taking this drug and start taking a different drug instead that has fewer side effects. And I'm like, oh, that's interesting. And she's like, yeah, and the symptoms stopped. So why did they stop? And of course, here I am having to say, well, I'm sorry, but it is because you're getting older. She is kind enough to laugh about that, but it is, I mean, she's been on it forever, and now her body's reacting differently to this medication that she's been on for quite a long time. So, any symptom in an older adult, 60 and older about, needs to be considered a drug side effect, also known as an adverse drug effect. Use those two terms interchangeably until we can prove otherwise, especially if a drug has recently been added or a dose has recently been increased. Now, added or increased. So they're not quite as worried about things that have been removed or things that have been decreased, but anything that has been added or increased may be problematic. We know that older adults use about a third of all prescription medications and half of those medications that are sold over the counter, and medications can certainly improve quality of life, but every single medication has side effects, so they can also increase morbidity and mortality. What's that mean? It basically means that it can increase their chance of death, right? Older adults are also at greater risk to be on multiple medications. This is termed polypharmacy. 4 or more medications is considered polypharmacy. Older adults are at higher risk for experiencing adverse drug reactions. Remember, that's the same as side effects. And to inappropriately use medications. That doesn't mean everyone inappropriately uses medications, but I could tell you a bajillion stories with just my family where medications have been inappropriately used. But let's use an example that's not from my family. So a friend of mine who worked on another unit said they had an interesting case in, and we were talking about it. And we went to nursing school together, so we bring up interesting cases because it stimulates our brains, and we like to make sure we're on top of things. And it was something she hadn't seen before, and it was a 19-year-old who'd come in with a pretty good GI bleed, and they couldn't figure out why. Healthy 19-year-old guy was having a GI bleed. So, what medications are you on? They go through this list. He's been in, he's gets this GI bleed taken care of, he's getting extra blood, he's been in for a couple days, because this is 20 years ago, and they can't figure out why he had this GI bleed. So how do we fix this problem? And finally, somebody asked about over-the-counter medicines. And I don't think that the person really understood what that meant, and so they asked it in a different way, and asked about Tylenol and ibuprofen and vitamins and things like that, and oh yeah, I take ibuprofen. He didn't consider ibuprofen a medication, first of all, because he could buy it at the grocery store, and secondly, he was taking it by the handful every couple of hours like candy. Well, it's no wonder he had a GI bleed, right? You guys know what the side effects of ibuprofen can be. So it's really important to explore how people are taking their medication, and some other issues. We'll talk about some that are more specific for older adults here in a little bit. Oh, I'm sorry that this didn't show up on the slide very well, but it is on your handout. Drug therapy in the emergency department and during hospitalization. It's a great place to identify polypharmacy, and it is a wonderful place to always say, hey, the next time you come to see us, bring all your medications in so we can really take a good look at what you're taking. Ziploc bag. That's what this slide actually says, and it's, we can put our medications, we could put them in a sandwich size bag, we could put them in a quart size bag, they could be in a gallon size bag, or they could be in a big shopping bag. The people who have medications in a sandwich size bag, are usually not at high risk for polypharmacy, but any of the others are. We did that seminar number 1 with medications in a gallon size bag, and there weren't a lot. You might think there were, but you guys know what your patient's medications list look like in the hospital. They look like that at home too. I've had people bring in 2 Walmart size bags, a whole bag, brown grocery sack full. And you just never know what you're going to find. So you really need to go through all of the medications that they actually have frequently and make sure we can get rid of ones that they shouldn't be taking, and make note of all the medications that they are taking, and then find out how they're taking them. So again, sorry about this one on the slide, but we also want to identify medications that have high potential adverse reactions, and because it could be the cause of an emergency room visit. It could be why they're there. So digitalis, digoxin, can cause renal insufficiency. It can cause problems with nausea and vomiting, and it has a really narrow therapeutic range. We'll talk about it more later. It's still a medication we use with older adults, but we do want to pay close attention. Aricept, patients on Aricept are prone to dehydration and diarrhea. Patients on vancomycin are prone to hemorrhaging. Is that what that says? I can't see it. Hearing loss, I think. Nah, that's not right. That's horrible. Okay, check your slide. Um, Leukocytes, we have people who have problems with colitis. You could go through the whole list and see lots of different things that can happen based on a medication. For individuals with dementia, benzodiazepines actually can make dementia patients much less inhibited, so they act out more. And then there are some big psychiatric side effects that we'll talk about a little bit later on. So, why are they a problem for the older adult? We've mentioned in the beginning that the body has some changes that they undergo. They have composition changes, physiological changes. We talked about polypharmacy. There's that comorbidity of multiple diseases and symptoms. And then inappropriate use of medications. Sometimes this is called non-compliance or lack of adherence in some cases. All of those are particularly problematic. But you can also see that as a person grows over time, their body shape also changes. And that means that their water balance changes quite a bit. So when their body composition begins to change, we actually find that an individual who's older has decreased body water than a younger adult. We talked about this. They have a decreased thirst, and why they had a decreased thirst. And that had a lot to do with aldosterone and renin, and how those hormones in the RAAS system actually function. They have increased satiety, so that means that they get full sooner. They also feel like they're not thirsty sooner, and their renal function is decreasing. Because of these changes, they have an increased body fat percentage in relation to their lean body mass, and decreased muscle masses. So everything they do from the time they put that pill in their mouth until they've excreted it completely through their system has changed. We'll go through each step here in just a bit. So, physiological changes: cardiac, GI, renal, and liver or hepatic. I'm bouncing all over. Just like we talked about in cardiac, remember we have cardiac age-related changes. I highlighted 3 things that are particularly of importance on this slide: impaired cardiac function due to aging, reduced cardiac reserve. It's evidenced by, we can see why they have reduced cardiac reserve, because their heart rate, their maximum heart rate is lower, their stroke volume, cardiac output, and ejection fraction are lower. And this all results in an increased myocardial oxygen uptake. That means the heart muscle itself needs more oxygen to function well. And that can be problematic. The digestive system, we talked about this too. So the teeth become loose, they lose enamel, they become vulnerable to tooth decay again. But more importantly in here that we should highlight is the gastric acid secretion is altered, the endocrine functions slow, and vitamin B12 absorption is disrupted. Those 3 items actually, let's see, right here. Oh, I was hoping I could draw on this screen. Those items are what really change the GI system and make medications go through the GI system for metabolism and absorption differently. Our kidneys, we have a decreased glomerular filtration rate, or GFR. That means our creatinine clearance is changed, right? It's also decreased. This is one of the reasons why we have a potential for dehydration, because we have a decreased urine concentrating ability and a decreased thirst. When we don't take in enough fluids, then our kidneys will show a little bit of renal insufficiency. We might see a higher potassium level and certainly an increased creatinine, but we're not going to excrete drugs like we should. In the liver, the older adults' liver function tests remain really close to normal. That's great news, but the ability of the liver to metabolize definitely still decreases. So the drugs have more side effects related to that. We also can see chronic inflammation in the liver and changes in growth factors and hormones and gallstones that are more likely to form. This slide is just kind of got a whole overview of system by system that shows you all the different changes that are happening in the body because of aging. It might be your quick and dirty review slide when you want to review for the test because everything's on one slide instead of multiple slides. Use it if it works for you. If it doesn't, then slip it aside. Here's just kind of an overview of pharmacokinetics, and we have to go through the GI system and the liver, and if it goes into the lungs, we have to do that, the kidneys, before it finally gets excreted. Just an overview. Is not anything you need to memorize, but sometimes different visuals do help people. So remember that all of these areas do impact things like the amount of bile or the way the stomach gastric acid impacts the system. So for absorption, we have that increased gastric pH and decreased esophageal motility. Not only in the esophagus, but it's through the entire GI system. So we have delayed gastric emptying and slower intestinal motility. That means that our meds that we have orally are just simply less efficient. Also, the absorption of IM meds, sub-Q meds, and even in transdermal forms, are less efficient because of the change in the lean muscle mass to fat. So we see all forms of medications have less efficient absorption processes. Distribution, those changes in circulation and membrane permeability. Protein levels, we talked about low serum albumin. And with low serum albumin, we'll actually see that we have an increased unbound drug, which is the active part of the drug, and more competition among other highly protein-bound drugs like digoxin, Lasix or furosemide, warfarin, or Coumadin. And then that change in the ratio of body fat to body water is why we end up with higher than normal concentrations of fat-soluble drugs. So the GI system has a lot of impact on drug absorption, availability, and elimination. Again, this is another way to think about that and how the GI system impacts all of those areas, from gastric emptying and intestinal motility, and even just the pH of the blood and the viscosity. Altered metabolism and excretion. The kidneys have that 50% reduction in blood flow due to the decreased cardiac output. That's a huge difference in renal blood flow. We also have lost quite a number of neurons. We'll have an increased non-functioning neurons. We talked about the glomerular filtration rate and how that's reduced. So what this all comes down to is at the bottom. Our half-life of drugs is increased up to 40%. If the half-life is increased, that means it takes longer to eliminate that drug from the system. So for heparin, it takes an hour is the half-life. So it takes an hour for half of the medication to leave our system. That means that really pretty quick I can turn that medicine off, and that'll start leaving the patient's system, and their ability to clot will increase. But if the half-life is increased even further, up to almost 40%, then it's going to take nearly 2 hours to achieve the same effect. And that makes a huge difference. For drug metabolism, we know that normal levels of enzymes convert those drugs to metabolites, but because adults are older, we don't have those normal levels of enzymes. And so it makes it much harder, and it takes longer before we can convert those drugs into metabolites. Our liver and our kidneys, again, I think we pretty much hit kidneys pretty well thus far, so I'll just talk about the liver on this slide. We know that there's a decrease in mass and function, and the blood flow is about 45% decreased. We have a reduced efficiency of enzymes, so that means that we have trouble detoxifying and conjugating drugs so that we can excrete them. That results in an increased circulation of the active drug, and that was on unbound protein, right? And that means our patients are at higher risk for drug toxicity, especially in medications that have a more narrow therapeutic range. So pharmacodynamics are also altered. We'll see a lot of adverse drug reactions with individuals who take anticholinergic drugs. Anticholinergic drugs are, of course, pretty common drugs, and they're one of those drugs that make you kind of feel like you got that tacky, dry mouth, like a cold medicine or allergy tablet, and you're like, I need more fluids, because that drug has helped dry things out a little bit. We also see decreased baroreceptor response. That means our patients are at higher risk for orthostatic hypotension and dehydration. They're already at risk of dehydration, and now we're going to put them at risk for another reason. So they're twice as at risk for dehydration, probably 4 or 5 times actually. The adrenergic system also doesn't respond quite as good. It's just not as rigorous. So we have a decreased sensitivity to beta agonists and beta blockers. Beta blockers, of course, are things like low pressor that help slow and strengthen the heart rate. And if we don't respond as well, then we're going to need a higher dose than we might need for a younger person of the same body shape and size. And we have increased sensitivity to diuretics. And that makes diuretics work a whole lot better than a beta blocker to treat hypertension, for example, in older adults. That is the end of the part 1 of the Geropharmacology lecture, and we'll have part 2 that's just as engaging in just a few moments.